Good morning. I'm Ruth O'Hara. I'm a member of Stand Up Laconia, which is a grassroots organization that has brought community members together to work on the issues surrounding substance abuse in our community. And this morning, Jackie Abakoff, who is a licensed social worker, and Ladak, which is a licensed alcohol and drug counselor with over 28 years of experience, is here. She's the executive director of Horizons Counseling Center in Guilford. She also serves on the New Hampshire Board of Licensing for Alcohol and Drug Counseling Professionals.
I just retired from that position.
Oh my goodness, can you edit this? Okay. Jackie has over 28 years of experience in mental health and addiction counseling, and Dr. Paul Rassicott is also with us. He is the president of the medical staff at LRGH. Paul has 33 years of experience in emergency medicine, having served as an ER physician for many years. Paul is also medical director for the Nathan Brody Outpatient Treatment Program for Drug and Alcohol Recovery. Together they have deep and firsthand knowledge of the issues surrounding substance misuse. And so we wanted to explore this morning the impact on our community of substance misuse, and not just the current heroin problem, but substance misuse in all of its aspects. I'd like to start with what changes they've seen over the past, say, 25 years in treating addictions. And Jackie, would you like to start?
Oh, sure. Thank you. Thank you for having me here this morning. It's really such an important topic to talk about. And well, as Ruth told you, I've been working in this area in the Lakes region for close to 30 years at this point. And Horizons Counseling Center provides outpatient treatment as well as intensive outpatient treatment through the Nathan Brody program at Horizons. And over the years, what we have seen is that not only is the instance of substance use and addiction increasing significantly, but what we've seen is there have been cyclical patterns with the use of different drugs. Right now, what we talk about is the heroin epidemic and the number of young people that we see dying dramatically in our community. And the number of people that we see through our programs who are addicted to opioids and heroin are enormous. They make up probably 70% of the folks that we are seeing on a regular basis. This is a huge change over the last probably 2 to 3 years. Prior to that, we were seeing mostly pain pills and marijuana and alcohol. Today, we're seeing tons and tons of heroin. But what we need to be aware of is that before heroin came Percocets and other opioids. Before that, there was cocaine. Before that, there was methamphetamine, and the drug changes, but the devastation to our families and to our young people and to our community and to the finances that we need to put into helping families combat this disease doesn't change.
And Paul, what have you seen over the years?
Well, I think, Ruth, having done emergency medicine for 25, 30 years, it was rare early in my career to see a death, an overdose death. As Jackie said, there was a steady amount of patients using stimulants more early on, cocaine and things like that. Really the pill epidemic in this country started in the 1980s. And it's a fascinating story in that a lot of it was driven by Big Pharma because a narcotic, long-acting narcotic called OxyContin was invented by a very small drug firm. And when Big Pharma sort of saw the potential for that drug, which unfortunately a lot of the medical literature, which has now been debunked at the time, was saying the addiction rate on this new long-acting narcotic was less than 1%. And because you were satisfying pain for 12 hours, people weren't piggybacking onto that. And once OxyContin hit in the 1980s and Big Pharma grabbed it, the next thing was create a crisis. And the crisis was most of America is walking around in pain, and it's a national crisis. And if you don't relieve every bit of that pain in the emergency room or in the doctor's office, then your scores are going to go down for patient satisfaction and reimbursement. So it was almost a fabricated crisis because most of America wasn't walking around in pain, and OxyContin was like putting gasoline on a wildfire because the pill addiction came first, and then more and more heroin addicts as we tried to clean up a lot of the pill mills and pill addiction. And really the overdoses that we're seeing now causing death, unfortunately, a lot of those batches of heroin have significant amount of fentanyl, which is a short-acting, extremely potent narcotic, much more potent than heroin. And we literally see seasoned addicts dying with their needle in their arm, which you would never have expected. So the spike in deaths really parallels the spike of addition of fentanyl, in my opinion. And I think it's not, the fentanyl doesn't come from prescription drugs. It's not doctors writing for fentanyl patches for end-stage cancer patients. Because fentanyl isn't a widely prescribed drug. It's bulk fentanyl coming out of Mexico that is, they also call it bathtub fentanyl because they make it in big batches. And I think if we can get a handle on fentanyl, we certainly can make an impact in deaths, overdose deaths.
Yeah, Ruth, I think the thing that's really important to understand, though, is that addiction is more than just those dramatic deaths of instant overdoses. That we have people dying from alcohol. More people die from complications of alcohol than from heroin. We have people dying from methamphetamine. Methamphetamine is making a move into this community like we have never seen before. And people don't die immediately from overdose, but they die over time. And we don't see that in the statistics because often those deaths get attributed to other reasons, to the complications from those drugs. And yet, if we do not recognize the need to treat the addiction, not just to treat the consequences of the specific drug, we're going to continue to lose people.
So how are these addictions impacting the delivery of healthcare, whether it's mental health care or primary care, care in the ER? Are you seeing a far greater number of people with addiction issues, and are they taking up more resources, be they time, money?
Yeah, I think the money part for the medical care is off the charts. As I tell my medical students, young narcotic addicts are extremely ill people. We're dealing with huge abscesses in the arms and the veins that require weeks of hospitalization, colonized with MRSA. We're seeing heroin addicts that seed infection onto their cardiac valves, 6 weeks, 8 weeks of antibiotics, sometimes a valve replacement. So, you sort of think these are healthy young people. They're not. They become very unhealthy quickly when you're injecting a narcotic into your vein with all kinds of other impurities and problems. So the medical costs, and you can look at all kinds of data, but the cost of treatment is minuscule compared to what these kinds of problems end up costing us in the medical community. Not to mention ER visits, and the overdoses, and how many times fire department has to respond to overdoses. And I think Jackie would agree, funneling some resources into very underfunded treatment programs is going to give you a huge amount of bang for your buck. In some of the programs I'm talking about, not just Jackie's program, but the kind of programs like the Mayor's Drug Task Force in Franklin, a small grant that's doing a lot of work in the schools. And in the schools, I mean grammar school. I mean identifying children at risk whose parents are using drugs, because that's just going to perpetuate if we don't intervene in those households. So I guess what I've learned is the treatment part is cheap compared to the medical costs of addiction. Wouldn't you say, Jackie?
Absolutely. It's not just in terms of the medical costs. The medical costs, I agree, are huge. And the number of clients that we get in our programs who come from referrals through the emergency room, referrals through their addiction being discovered when they're in the hospital for other medical problems that then become discovered that those are secondary to a drug addiction, has skyrocketed. But the other piece that we really need to look at is our criminal justice system and the costs that we spend on keeping people incarcerated because of both drug-related offenses and offenses that are driven by addiction. People will do desperate things in order to feed their addiction because as your addiction progresses, your ability to make judgment decreases, and the desperation to get that next drug, that next use is unimaginable. And so people will do desperate things that they would never have considered doing prior to that. And it's very expensive to house someone in a house of corrections or to house someone in a prison for an extended period of time. But the other thing that we have to realize is we're going to let them out. You can't keep them there forever. You can't keep them away from their drugs forever. And unless we treat the underlying disease, they're going to get out and go back and commit crimes again. And the cost of treatment is a fraction of the cost of incarceration. That's why in Belknap County we're really lucky, and Horizons and Nathan Brody program are really lucky, are really pleased to be part of the recovery court program that Judge Carroll has overseen for the last few years. Because what we are seeing is the ability to take people out of the prison system and out of the jail system and put them through intensive treatment with monitoring to make sure that they're doing the treatment that they need. Unfortunately, as Paul said, those programs are grossly underfunded. And so a program that keeps so many people out of jail can only handle 10 people at a time because that's all that's allowed. That's only a fraction of what needs to be in that program.
Now, the Community Correction Center that was just approved, that's a few years out, but that will help with getting...
Yes.
And so will that be funded to create the treatment that people need while they're incarcerated?
Yes.
Preparing them to get out?
Yes, as a matter of fact, the county has approved sort of a demonstration project. It's a small version of what they want to see happen when the Community Corrections program opens. And that program, called the CORE program, and the treatment for that program is being offered by Horizons. And that program just got started approximately 2 or 3 weeks ago.
Oh, excellent.
And has started its first seven clients, and there are 3 more who are going to be in the process of being evaluated for appropriateness for that program. They're going to go through 3 months of intensive treatments before they will be let back into the community. And it's going to be a step down so that when they finish the intensive treatment portion, they will then be allowed to work in the community through work release and possibly be released on community corrections or the bracelet program, at which point they can now transition their treatment into the community-based programs where they can initiate follow-up treatment while they're still under the jurisdiction of the Department of Corrections. And by the time they're released from the jurisdiction, they're already engaged in community-based treatment and hopefully motivated to stay there.
So I think that's important, Ruth, because this is, for years and years, we've always lamented the fact that these folks are in a captured environment, yet we're not able to provide them treatment in that setting because of funding. So this is exciting, and I think it's a big breakthrough, because really the model should be, probably shorter incarcerations for drug-related issues in treatment as a big part of the incarceration, because otherwise you're not getting to the root of the problem. I mean, I don't know how many heroin addicts that tell me they used within an hour of leaving prison, some in the prison parking lot. And some of them, even the state prison, have been there 3 or 4 years, no treatment, and they will use before they get home. So I think we've got to try to make an impact there. And again, this is short money, in my opinion. It's not a lot of money compared to the overall medical costs. And when you look at costs, you have to expand it to what does someone addicted to narcotics or alcohol or any other drug do to a family. And I see families in this area that have second mortgage their home, second and third mortgage on their business, spent hundreds of thousands of dollars in trying to get help and treatment. So the economic impact there is huge, but also when you look at it as a community, say the Twin Rivers area, our estimate, probably conservative estimate, is probably 200 to 300 very heavy heroin users. And you look at the lost time from work, you look at the fact that a lot of them lose their job, but also you have to understand that our males are using 2 to 3 grams of heroin a day, sometimes more. A lot of them need $1,000 every 5 days, and you can do the math. That means our community needs $300,000 every 5 days, or every 15 days, $1 million. And as Jackie said, almost everyone has to deal or steal or both. So the hard thing for the police is it's not a kingpin heroin dealer sitting in the middle of the city that you can figure out and bring down. Almost every user is also a seller and a dealer, because that's how they're keeping their habit going. So for the police department, the hard thing is you put out this fire, this fire, this fire, this fire, and most all of them are getting their drugs in bulk outside of this state. They're driving to some of the cities in northern Massachusetts. So the economic impact, a small area like ours, not a huge wealthy area, to be pulling $1 million out every, a couple times a month to put in veins to ruin health, that drives up healthcare costs, and then families spending tons of money for treatment. It's, we've got to get affordable treatment covered by all medical plans, so that we can spend some money up front.
But we know that we can't arrest our way out of this.
No,
That's ineffective.
And I hear a lot of times in the community, I'll hear, well, if the police would just get rid of the dealers. I think what the community doesn't understand is there's hundreds and hundreds of small-time dealers funding their own habit by selling to 3 or 4 or 5 other people. So and believe me, as soon as they put out one of those fires, there's a whole new crop and generation coming up right now in high school that are experimenting with pills, and then they're into heroin within a couple of years.
Yeah, the thing that's, from the treatment perspective, that's really frightening is it used to be, if you went back 20 years, it used to be that when you worked with teenagers who were using, they told you that the first drug they used was alcohol. Sometimes the first drug they used was marijuana. Today they're telling us the first drug they ever used was Percocet. I mean, that's a frightening thought, that the fear of those types of drugs has gone down so much that in the past they would say, well, I'm not using hard drugs. Now they're saying, well, it's only Percocet. It's a prescribed drug. My mother takes it for pain. It has to be safe, or the doctor prescribes it. And the understanding that just because the doctor prescribes it doesn't make it safe. The doctor gives, hopefully, instructions on how to use it safely. Using it for what it was not intended is not safe. Using it recreationally is not safe. But kids are invincible when they're
Absolutely.
15 and 16 and 17, and it will never happen to them. And so we're seeing this generational perpetuation of this disease. And the thing that I find frightening, and Paul, I think you'd agree with this also, is that when someone has diabetes or when someone has heart disease, we understand that there is a hereditary genetic impact of that on future generations. And we look at that when we look at examining young people and teaching them what they need to know about healthy eating. And yet, we are seeing the grandchildren, the children and the grandchildren of addicts that we saw 25 years ago. And the preparation for these young people about their risks for addiction happens after the fact, not before the fact. Prevention is such an important piece. Getting it into the schools, getting kids to understand what their risk factors are. But prevention starts with treatment. If we could get mom and dad to treat their disease, that's the first step in preventing that disease from devastating the next generation.
It's true.
Yeah, there is a big genetic component, certainly, and there's just a big prevalence in the general population. You know, we know now that, you know, the addiction rate of these narcotics isn't 1%. It's pretty steady at 10%. When I look back at, you know, what's the addiction rate of alcohol, meaning of how many people drink are going to have a problem? It's about 10%. It's about 10% for marijuana. It's about 10% for narcotics. The difference is people can drink for many, many years, but when you're taking narcotics, the cycle of severe addiction is really accelerated. I mean, Jackie and I will tell you, 90% of my stories are all the same. It's you know, a male smoking marijuana daily in junior high and high school, bored by late high school, starting to choose some Percocet or Vicodin, almost always pills that were sort of part of a prescription, but still in the medicine cabinet, or from friends. But they've moved on, usually a year out of high school, to heroin. And a year later, they're in our program because they're a mess. They've hit bottom, and I think that's the story we see. With females, the story I see is usually a boyfriend started them, and it's usually an older boyfriend. And oftentimes for females, I think 25% have had an issue with some sort of abuse, sexual, physical, growing up, and some of that is self-medicating as well. But the cycle is almost always the same in this community, and it's not an socioeconomic issue, because I don't know how many star athletes and star quarterbacks we have seen in our clinic who even started college, but they usually don't make it through 1 year because the cost of the addiction and the amount of time you need to procure enough money to satisfy that just becomes all-encompassing. It's a 24/7 job. And I often tell my medical students, you know, the stimulation of these narcotics and the pleasure is so high that it breaks the basic bond of nature, which is a mother will ignore their child, watch their child not eat, not drink, sit in soiled diapers in order to get high. So, you know, that's breaking a basic bond of the animal kingdom. So you know that the centers and the receptors being stimulated is off the scale.
I also think it's really important to understand that we get really frustrated with addicts because it's a relapsing disease. I can't tell you how many people I hear say treatment doesn't work. How many times does the same person recycle through the treatment process? And the reality is that's true for all kinds of diseases. How many people stop taking their high blood pressure medication because they don't feel sick and they think they can do it without it? How many diabetics don't adhere to their diabetic diet, don't take their medication appropriately?
Well, and certainly
Thank you for volunteering that.
Even obesity. How many people go on and off diets?
Exactly. And but there's a stigma attached to using drugs and even to using alcohol, because we blame the victim of the disease. We say, if you never started using, you wouldn't have become an addict to begin with. And yet we're a society that says, oh, you have a headache, here, take a pill, it'll make you feel better. Oh, you have a birthday, here, let's toast to your birthday or to your wedding. And it is such a frightening thought that we then blame these people when they become addicted and they can't grasp it the first time. And we have to begin to understand that these people are using, addicts are using incredible amounts of resources, emergency rooms, jails, prisons, the stretched thin treatment center. But what happens is, somebody goes into the emergency room and says, I'm in a tremendous amount of pain, and the providers go, you shouldn't be in this much pain. Addiction lowers your tolerance to pain. It's the way it perpetuates itself. We need to begin to understand the disease in order to be more tolerant of those people who present with it.
One of the things I've heard you kind of say is, in order to achieve prevention, we really need to act very early, getting into the schools, doing assessments of these kids' environments, and getting interventions to keep them from following that same pattern, because there's the genetic component and then there's the familial, what you see around you.
Right.
Would you agree that where we're going to be the most effective for prevention would be schools?
Yes, I think that,
And pediatricians' offices.
Yeah, and younger. I think parents are. You can reach parents very successfully in the workplace at noontime at their lunches. I think those are the kinds of interventions that we also have to be doing. But I guess in 25 years, I think I've gone with more money for intervention treatment even earlier than we were ever thinking, because the seasoned heroin addict is a very long-term, difficult case, and I think the more we expend up front, the less problem we'll have. And quite frankly, treatment programs operate on a shoestring. I mean, Jackie doesn't know where her money's coming from year to year. She has to piece together grants, and really, it's not a lot of money.
No, it's not.
To run one of these. So I think we need more funding for these kinds of programs, and it's money well spent.
We need to make a commitment to getting behind Medicaid expansion and making sure that it doesn't go away in this state, because suddenly we've gotten all of these people who now can afford to access treatment and to do it normally the way anyone would access any medical care. It's a step at destigmatizing access to treatment.
Well, thank you very much for coming and talking this morning about this problem, and hopefully, another 25 years, and there will be good programs. I don't think it's going to happen overnight, but by working on it constantly. And thank you so much for what you both do.
Thank you, Ruth.
Thank you.